Hey everybody, Global CE Day. Tom Judd of CED, having the privilege of interviewing my longtime friend and colleague, Dr. Ricardo Silva. So Ricardo, so the family's in Orlando these days, huh?
That's correct, Tom. Now I'm here in the U.S.
Well, I know, from Venezuela and did a lot of great things there, and we're, leapfrogged a lot of the mistakes we made in the North America with your work in digital health, and then great work in Ecuador and now in Orlando. And hey, we're coming to visit you next year. Tell us a little bit about your work as a professor now.
As a professor now, well, I'm teaching health informatics at Villanova University, mostly online. So I've actually built out of all of my experience in Latin America and here in the United States, and now helping with the digital curriculum for health informaticists here in the U.S.
So I know you and your colleague, Dr. Elliott Sloan, do a lot of online teaching, and I know that's perhaps what you're talking about for Villanova.
Mm-hmm.
You and Elliott have been working with several academic institutions in Latin America and across the world about including digital health in their curriculum. Can you say more about that?
Correct. So there is a big movement actually in Colombia. Several universities from the coastal area of Colombia have built a partnership, and they actually want to make a core curriculum for digital health as related to biomedical engineering. So it is a biomedical engineering graduate program with emphasis in digital health and health information technology. Also work with a couple of universities in Ecuador, also developing digital health curriculum. And I've assisted a couple of colleagues in Mexico. I actually have a good relationship with Mexico ongoing for actually not just digital health, but what we assume should be the new role for clinical engineers.
Well, you were one of the masterminds of several programs this year. I'm thinking particularly about the digital health webinar we did, and we gathered some great experts from around the world. Some of your thoughts on that particular program?
It's needed. So up to this time, digital health has been split among several disciplines. The folks from computer sciences and engineering have devoted to a part of digital health. Then you have the medical doctors that have helped build all of the electronic health records. And then you have the biologists and then the computational biologists that have built the bioinformatics curriculum. But up to this point, they are all disaggregated. And in fact, there's one piece that is mostly missing in this puzzle, that is the specific contribution of clinical engineering or health information technology and the part of digital health that corresponds to the biomedical engineers. So digital health has been focused on the computational side and how do we automate things. But there's another major component that has to do with all of the supply chain and all of the support. So how are we sure that all of these new distributed technologies, Internet of Medical Things, they are secure, they're calibrated, they are properly connected, they do not become a vulnerability for the health system. So there's a big missing piece that should be covered by biomedical, clinical, health information technologists, and that is something that we definitely need to develop.
Well, Ricardo, you've been an innovator yourself. I know you're involved in developing some new products today, but just before you tell us about those, telehealth, we just had this big webinar, 10 days ago now, yeah, about that. That's an aspect of digital health that's changing healthcare delivery. So tell us about telehealth, and then I'll ask you about some stuff you're working on.
Absolutely. So I've actually been working in telehealth for, over 15 years, started with rural telehealth in Venezuela. In fact, developed some technologies that could be connected to a rural clinic so that a nurse or a nurse practitioner or even an indigenous shaman and doctor, herb doctor could actually communicate with the capital and by remote connection and some tools help diagnose and treat people in very poor rural areas. So that was my original contact with telehealth and telemedicine. And for a long time, telehealth and telemedicine was seen as something for remote rural areas and locations. But truth be told, actually, telehealth and telemedicine becomes a very cost-effective way of performing the majority of the medical tasks that are usually associated with either a primary care practice or an urgent care practice. So many times people go to an urgent care because they have a sore throat or because they have a rash and they have no idea what the rash might be or what's causing the sore throat. And actually with current technology, that could very well and easily be assessed by a televisit. So that improves efficacy of the practices, reduce times, reduce cost. So it's a completely different take on healthcare, on how should we actually take care of our patients in a more convenient way. So rather than having to drive, I don't know, half an hour, spend half an hour in a waiting room, then another half an hour visit. So you already spend half an hour to go back home. So you spend 2 hours in something that you could very easily call your medical provider, video conference your medical provider, and have it resolved within 15 minutes. So this shifts the paradigm on healthcare.
Well, I was mentioning you, in the midst of COVID, have been doing a lot of things, teaching and but also innovating. Tell us a little bit about, in closing here, the projects you're working on.
Yeah, well, we're currently working on a project for back to work. If you look at all of the CDC guidelines, one thing that they want is to be able to make sure that people are being monitored for signs, symptoms, and contact. So the question is, how could you make it easy and accessible? And what we've done is basically build a platform. It includes telehealth and telecoaching, but basically what it is, it's an app that allows employees, currently hospitality industry, allows them to daily record an assessment of how they're feeling and measure their temperature. And if there's anything out of range, then it automatically activates a response chain that includes coaches. Coaches will communicate, they will have a televisit with the employee, check if whatever they're feeling might be consistent with COVID or with any other contagious disease, so that the coach can help decide if this employee should go to work or not. And if the answer is that this person should not go to work, the employer automatically receives a notification knowing that the employee is sick and they cannot go to work, so they will not be showing up. So that way the employer can actually make the proper arrangements to replace this employee and know what's going on. In fact, if someone happens to test positive for COVID, then again, by knowing who went to work with this person or shared shift with this person, then we could backtrack and tell, well, all of these people may have been in contact with someone who tested COVID positive, so they should be tested. That way we can assure that everything is being done to keep the restaurant healthy, and therefore the patrons that are going to the restaurants, they can feel assured that the risk of eating outside is certainly reduced. So in order to bring back the clientele, in order to bring back the people and to reopen businesses, we need to be able to assure the population that this is a safe place and that by going there, the risk of getting sick has been clearly minimized. So,
Ricardo, what a great new practical tool. Thanks for working on that. Any closing comments for the Global Clinical Engineering Group here?
Well, what I've been telling lately a lot in many of the conferences I've been giving worldwide is that healthcare as we know it is in the verge of extinction. A new type of healthcare is currently being born. one where the hospital, the big place with a lot of beds, it's going to be less and less relevant, and health is going to be more and more distributed, more and more ubiquitous, where your hospitalization room is going to become your own room in your house with the Internet of Medical Devices, with higher speeds of communication. We're moving from the concentrated hospital to the distributed hospital. And this distributed hospital requires a new type of engineers that is able to think in a systems perspective and understand how to deal with these new type of health approach.
I love it. Thanks, Ricardo. Great being together with you.
Well, thank you, Tom.
See you
Have
next
a
year in
wonderful day.
Orlando.
We'll see you
Bye.
next year. Okay.
Bye.
Bye-bye.